All right, good morning and good afternoon to all of you. I'd like to thank you for taking time out of your busy schedules to join us today at the Institute for Safe Medication Practices for our webinar program entitled Introducing ISMP's New Targeted Medication Safety Best Practices for Community Pharmacy 2023-2024. My name is Matthew Grissinger. I'm the Director of Education at ISMP, and I'll be your host for today's program. And as we start off your new year with an eye on safety in the outpatient pharmacy setting, this webinar is hopefully going to inspire and mobilize practitioners from around the United States in a national adoption of specific consensus-based safe practices selected to reduce or eliminate repetitive medication safety issues in community pharmacies that have been reported to ISMP and continue to cause harmful and fatal errors to patients. During this webinar, you will learn about ISMP's new targeted medication safety best practices for community pharmacy and why they were selected for national action. And at this time, too, I want to also thank Novartis Name Creation and Regulatory Strategy for the generous support for this program. So a couple quick housekeeping items. Number one, this program is being recorded, and it will be available on ISMP sites shortly after the webinar is completed. Second, handouts for today's program can be found using the link provided in the reminder email that you received earlier today, as well as the Zoom chat box. The handouts you can find either on the top right of the webpage or in the very bottom of the webpage. And again, I'll even put something in the chat again. As a reminder, the link to the handouts are in the chat box as we speak. All attendees are in listen-only mode during the presentation. If you want to ask a question, feel free to ask it by accessing the Q&A functionality on your toolbar in the bottom of the toolbar in Zoom. We'll have time at the end for Q&A. There will be polling questions. There will be polling questions throughout today's webinar. When the polling question appears, please select your answer within the polling dialog box and not within the chat or Q&A box. So let's move to today's content. So I'll go over a couple of slides here for Mike. So you'll see in these next couple of slides here, these are disclosures for speakers today. Mike and I, you see we have no relevant financial relationships for today to disclose. Next slide, Mike. You also see some material from ProCE regarding disclosure of unlabeled use, which is not applied to today's presentation, as well as disclaimers, which you can see in the handouts later on here. Next slide, Mike. This is a statement from ProCE, who's doing CE for today's program, that you will get one contact hour of pharmacy CE through their website, and you'll see links at the beginning and end of the program to access the activity and get your CE. Next question, Mike. Next slide, I'm sorry. Also, just in case there's nurses on the line, we also got CE approval for nurses through Deborah Simmons and the California Board of Registered Nursing, and the provider number you see on the slide. The key thing is, like all CE, you have to attend the entire program to get credit for the CE. Next slide, Mike. Okay, so let's talk about today's learning objectives. So the objectives today are, number one, cite the 3 new best practices from the ISMP targeted medication safety best practices for community pharmacy. Describe the medication errors that each of these new best practices were designed to prevent. And third, describe recommended strategies related to ISMP targeted best practices for community pharmacy. So on this note, let me introduce our speaker, Mike Gaunt. Mike is the Senior Director of Error Reporting Programs and Editor at ISMP, which he joined in 2004. He supervises the ISMP National Medication Errors Reporting Program and the ISMP National Vaccine Error Reporting Program. In this role, he works collaboratively with the US FDA to advocate for nomenclature, packaging, labeling improvements to reduce the risk of error. He participates in on-site risk assessments in healthcare systems, particularly their ambulatory care areas and community pharmacies, to assess risk and identify opportunities to improve safety and reliability. He also serves as the editor of the monthly ISMP Medication Safety Alert Community Ambulatory Care newsletter. Mike has represented ISMP at several organizations and partnerships, including the National Coordinating Council for Medication Error Reporting and Prevention, NCCMERP, the Centers for Disease Control Prevention, or CDC Protect Initiative, as well as the Partnership for Health IT Patient Safety. He has made contributions to medication and health information technology safety science as a member of various grant-funded research teams. He's also published articles in patient safety and pharmacy literature, including a monthly column in Pharmacy Times. One note, I'm noticing that people aren't having access to the chat function, so let me work on that. In the meantime, I'm going to pass this over to Mike Gaunt and let him start the program.
All right, thank you, Matt. Appreciate the introduction. Good afternoon, good morning to everybody. Have quite a few folks on the webinar today, so that's great. Many of you are probably familiar with our mission. I just kind of wanted to throw this up for those, especially for those folks who aren't as familiar with ISMP and our mission to advance patient safety worldwide by empowering the healthcare community, really to prevent medication errors. The other reason I wanted to throw this up is I think as we go through the targets, the new targets, and talk about them, you'll really see how these really kind of embody a number of these different activities that we engage in to accomplish our mission, right? So from looking at medication error reports that you all send in to us, identifying these these targets, to writing about them, to then obviously doing things like this today, as well as just the targets in general, educating healthcare community about, really kind of key error issues we want folks to address, and then collaborating and advocating for safety improvements with you all as practitioners, as pharmacy providers, but also with regulators. And as you'll see, particularly trying to advocate for change from technology vendors to really kind of build in some of those higher level strategies to address some of these recurring issues that we see. And so, just as some background to set the stage for you all, we first introduced this concept of the ISMP targeted medication safety best practices back in 2014. And at the time, they were focused on the hospital setting. And since then, we've continued to update them every couple of years and issue new ones and sunset others. But really, the idea was to shed additional light and to inspire folks to address recurring safety issues that we were receiving that were leading to fatal or harmful events and errors. And so, certainly you've seen through our newsletters worth repeating, articles and things like that. And certainly this has happened for years with us as we publish things, and things keep happening that we publish. And certainly with these targets, not only they're harmful and potentially harmful and fatal errors as a result, but these are things that we weren't seeing lots of change despite having addressed them multiple times through our newsletters and through other avenues. And so we wanted to coalesce some practices around a few issues. And so now we are doing that on the community pharmacy side and introducing these targeted medication safety best practices for community pharmacy. And really the goal is to identify and inspire and mobilize, as Matt said, widespread adoption of these consensus-based best practices. So what did our process look like as far as the development? Obviously, like I mentioned, error reports, we've looked at those, as well as those that continue to happen. And then obviously looking at our newsletters and publications for things that we've continued to write about over the years. And from this, we drafted, I think it was about 12 potential targets, and then opened it up for internal ISMP staff to review and vote on. And so that we were able to distill it down into a smaller number, which we then shared with an external advisory panel for their feedback and review. And so what you'll see here today is kind of a result of all these different pieces coming together and distilling it down into these 5 best practices. And so once these are published and once you get your hands on them, really, it's our call to action for you all to focus on these 5 best practices and focus your safety efforts around these 5 best practices over the next 2-year time period. Come 2025, we'll introduce new ones, but for this initial set there are 5. And like I said, really hope you're able to focus some of your safety activities and improvement activities around these specific best practices. And so Matt, if you want to launch the first polling question.
You see it, Mike? There you go.
Yep, can see it. So yeah, so this first question is, have you been involved in or know of a wrong patient error at your practice site? Results are flooding in here. And not surprising, the vast majority of you have. Matt, because it's kind of slowing down.
Yeah. In the poll here.
All right, well, as you can see, 86% of you all have been involved in or know of a wrong patient error at your practice site. So, so thank you for participating in that. And so as it comes to no surprise, probably, especially given that the response, is really the first best practice is going to focus on preventing wrong patient errors. So for example, preventing giving a correctly dispensed medication to the wrong patient, say at the point of sale. We certainly know when looking at reports we receive from patients, because we do operate a reporting program specifically for consumers, that really wrong patient errors are one of the most commonly reported errors we get. Often, someone else's medication vial ending up in their bag of prescriptions. And, even this goes back a few years, and even longer than that, a number of years ago, we actually conducted some AHRQ funded research on errors that occurred during the community pharmacy dispensing processes. And that study found that, this type of wrong patient error, giving a correctly dispensed prescription to the wrong patient, occurs in about every 1,000 prescriptions. And so when we think about this kind of on a more global or national level, what does this really mean kind of on a monthly basis for community pharmacies? And so, like, just for numbers' sake, say, let's use 1 out of every 1,000 prescriptions dispensed figure that we found in the research and apply it to 4 billion prescriptions, that are dispensed each year. So some of these numbers might be a little off for the current year, but just for example's sake, this would mean that there are on average about 7 wrong patient errors happening each month at every pharmacy in the US. And of course, we know some of these projections are based on known errors, right? So when the research with focus groups, we were asking pharmacists to estimate how many errors they had. And so this is all predicated on the fact that we aren't even getting all the errors reported internally in pharmacies or to us as ISMP. So this figure is probably even higher. And there, as you know, I'm sure there are certainly a lot of different ways patient errors can happen, right? So they can happen pretty much at any point in time in the medication use process. They can happen at the prescribing end, but certainly a lot of different ways they happen within the pharmacy as well, whether it's hearing the wrong patient's name when you're on the phone with the prescriber, or even on the phone with the patient trying to look up their profile for a refill, selecting the wrong patient in the pharmacy computer system, selecting the wrong patient's bag from the will call area, or then even, certainly we've seen much more prevalence of this with the COVID pandemic, administering a vaccine to the wrong patient. But really what all these things have in common is the fact that the patient ends up getting the wrong medication or the wrong vaccine. Yeah, and just as there are many ways these wrong patient errors happen, certainly there are a number of factors that combine to contribute to these errors and allow them to reach patients, right? So if we think about placing the wrong patient's medication in the wrong bag for pickup, right? So I'm sure many of you can imagine, right, how distractions, at the pharmacy verification step um, can contribute to a medication, the wrong vial getting into the patient's bag. Or certainly we see reported a fair bit through our reporting programs where staff are working on more than one patient's prescription at a time. And then, of course, some other things that happen is, surrounds that kind of patient verification process. Oftentimes this may be flawed and you're not using two patient identifiers, for example, a full name and date of birth when you're interacting with patients on the phone, with prescribers, or at the point of sale. And certainly at the point of sale, we've had reports where, it's indicated that, staff feel like they know their patients and know them so well that they don't really have to go through those verification steps. And of course, that's, when these errors happen and things can get mixed up pretty easily. And then, of course, the other issue with this is that there are missed opportunities for actually catching these errors. And these are oftentimes missed in the pharmacy, but also missed, with the patient, right? So in the pharmacy, because of time constraints or perceived time constraints, it's thought that you can't really look at each medication vial with the patient, or maybe the patient wants to get out of the store really quickly. And so you're missing opportunities to actually look at those vials with the patient to verify it's the right patient, the right medication, things like that. And then when you even think about the patients going home, there are a lot of patients who don't ever look at the label when they get home, right? So they're not even verifying their name or drug in the home. And so this comes across through reports we get through the consumer reporting program, where they identify the error because they start experiencing adverse effects. And so, as you can imagine, there's certainly lots of different consequences of wrong patient errors, and this will get to some, our kind of criteria for, potential for harm, for these targets. Certainly, you have the possibility of taking a contraindicated medication. Patients may miss out on a medication that they're supposed to be getting, or they may misuse the incorrect medication that they end up receiving. And certainly, from a pharmacy standpoint, all these kind of present potential breaches of protected health information. But if we think about harm, we can think about this, the contraindicated medication scenario. And one of the examples we've received, we actually had a pregnant woman who was given methotrexate accidentally that was intended for another woman who had the same last name and very similar names. And the patient ended up taking the methotrexate. And at the time of the report, the outcome of the fetus was unknown, but certainly the potential for harm to the fetus, as well as the patient, was pretty high in that case. And the other one I just want to share is, in this case with the amitriptyline and the Premarin, a woman who had picked up her prescription for Premarin found that a medication for amitriptyline, antibiotic, for another patient was also in her bag when she arrived home. And normally, a lot of cases, patient will call back and tell the pharmacy, but in this case, the patient ended up taking that medication as well. And after a bit of time, the pharmacy actually received a call from a local hospital to inform that this woman was in the emergency department after taking 30 amitriptyline tablets in what appeared to be a suicide attempt. So certainly with these wrong patient errors, there are a lot of opportunities for serious harm. And so that brings us right to our best practice. And really here we want folks to develop and utilize a standard protocol to verify the patient's identity, using at least two patient identifiers. Most often that's going to probably be name and date of birth at least. But this is, for various points in kind of dispensing process, when you're receiving a prescription to be filled, right? Making sure you have that information from the prescriber. When you're interacting with patients on the phone, so you're using gathering those identifiers to make sure you're looking at the right information. like we've gone through here, when you're providing prescription at the point of sale. And even think about like when you have couriers, especially if they're pharmacy employed, couriers delivering prescriptions to the home, how you can employ those two identifiers to make sure they're actually delivering the medications to the correct home and the correct patient. And of course, then when administering vaccines or any other treatments in the pharmacy. And then, to go along with this, you want to not only be collecting this information, right? These two identifiers, but you need to have this process. This process has to incorporate, how you're going to use that information and to what you're going to compare it to verify that you have the correct patient. And so you're using that information to compare it to information within the pharmacy computer system or on the prescription or vial label or on the receipt. And really, again, here, we're hoping pharmacies can leverage technology, and many of you have, at the point of sale to really drive this patient identification process and not have it rely solely on human memory and intervention. And so things like using a blind prompt to have the technician, ask for the patient's date of birth and enter it into the point of sale system before the sale can be complete. And there may be other ways you can do this, and hopefully folks can think outside the box, but really thinking about how to leverage technology to collect and use multiple identifiers to verify the patient's identity. And of course, when you implement things, right, one of the key things is obviously monitoring that those interventions are successful. And so here, one of the ways you can do that with this is obviously doing some observation of that patient identification process at various points in the workflow. So whether it's at the point of sale or when you're doing order entry, managers or district personnel can get involved and periodically observe some of the standard work processes to make sure that they're still working and they're still being followed. And we're going to transition to the next best practice. And if you want to launch the next polling question, Matt, that'd be great. And here, ideally, this would have been, we could have set this up as all you can choose. But at which stage of which of the following stages do you employ barcode scanning? Hopefully, obviously, many of you are able to do it during the production for filling medications, but are you able to employ it for vaccine selection and preparation or vaccine administration even? Certainly know pharmacy operations that are hoping to push that envelope and get vaccine administration, barcode enabled. And certainly, if you have other comments, you can certainly use the functions. I don't know, Matt, is the chat function operating again, or just?
We're gonna find out, Mike.
Okay. If you're doing multiple of these, you can obviously use the chat function to let us know about that too. So looks like it's slowing down, Matt.
Yep, let me end it now.
So yeah, so obviously 3/4 of you are using it for production or that prescription filling of medications, and some are doing it for vaccine administration. That's awesome. There are still some who don't have it available at all, and that we certainly see that expressed through the error reports we get. And that's one of the reasons why this next best practice is really focusing on that the implementation of barcode scanning. And so certainly, like I think most of us and a lot of folks and consumers assume that there's lots of technology employed in all the pharmacies across the nation. Of course, that's the case to a large extent. When certainly from a computer standpoint, a little bit less when it comes to the barcode scanning standpoints. But even in those situations where barcode scanning is available for production, we're certainly seeing reports where it's either not being used fully, or there are being workarounds employed, right, to kind of get around potentially system limitations or other limitations within the medication use system. And so certainly, whether it's available or not, in the case of all these workarounds, certainly we're still seeing errors happen and reach patients. And so here's one example that you can see on the screen on the slide here. In this case, it involves a robot, filling a robot, but it could just as easily happen during a manual filling of a prescription. But in this case, the pharmacy was using a dispensing robot, and they were trying to refill it. But in the process of refilling one of the cassettes with trazodone, the technician also had picked up a bottle of topiramate, and both these medications were added to the same bin within the robot. And in part, this is because the system only required a scanning of a single bottle. In this case, fortunately, the pharmacist was able to catch the error before it actually reached any of the patients after the robot had filled the prescription. They were verifying it. In another example, here is involving cartons of topical creams. And here, prescription for triamcinolone, a corticosteroid, used for relieving inflammation and pruritus, was dispensed in this case for a 6-month-old patient. But when the pharmacy staff actually went to the shelf to grab the product, they actually retrieved tretinoin cream, and they actually applied the triamcinolone label to that carton. So obviously, not surprising. This child experienced some adverse effects with skin irritation and breakdowns of the skin where the cream had been applied. And this wasn't really picked up until they actually took the child back to the prescriber, to the physician, because of these adverse effects. And so certainly, these cartons do look alike, so it's not surprising you could select the wrong carton from the shelf. But I wanted to point out here, in this case, the pharmacy, in the report that they sent us, noted that what also contributed to this case, and probably more so than the packaging, was that the staff had bypassed scanning the product's barcode during the filling process, and instead they actually manually entered the National Drug Code, or NDC, into the pharmacy system to get this to progress through to the next stage of the workflow. And the final example I just want to touch on real quick, and this we just published in the December Community Ambulatory Care newsletter. And here, a patient was supposed to be receiving prasugrel, 10 milligrams, which is an antiplatelet agent, but was inadvertently given methotrexate, 2.5 milligrams. And as you can see here in this picture, the pharmacy had actually applied the prasugrel label to a manufactured bottle of methotrexate. And so this patient ended up taking methotrexate daily for about 3 months. And over that course of time, experienced worsening symptoms and adverse effects from arm and joint pain to hair loss. And at the time that they'd actually shared the report with us, the patient was still not feeling well and was undergoing additional tests and monitoring. One thing, luckily, though, even though they were experiencing adverse effects from the methotrexate, at the time they weren't experiencing any of the really severe effects, from a mild suppression standpoint, or life-threatening pulmonary symptoms. And also, they didn't experience any thrombotic events, despite not having the prasugrel. So here, there are a few different ways this error could happen in pharmacies. So we heard about this from the consumer, so we don't have all the insight into the pharmacy end of things. But again, certainly staff could have been working on prescriptions for multiple patients at a single time. I'm sure most of you can envision that. Or possibly, right, the methotrexate was sitting on the counter because the technician or someone had pulled it in anticipation of using it for a different patient. But then obviously here, these involve these blue vials. And so certainly some of the look-alike similarities could have contributed to this. But certainly, effective barcode scanning at any point here in the process likely would have caught this error. And I share this screen just to kind of give you some other examples of some of those barcode workarounds. Some we talked about already, from working on more than one patient's prescription at a time, to some of that manual entry of NDC codes. But certainly I wanted to focus in, and I did mention it before, but that piece about scanning only one container several times when multiple containers are required to fill the order. Certainly we see that a fair bit of time in reports that we receive both from pharmacies and patients, where even when multiple manufactured bottles are dispensed to the patient, they get a mix between strengths or drugs, presumably because each of those containers aren't being scanned, or maybe can't be scanned, given the current state of technology. So this brings us to the best practice language. And like I mentioned before, right, many of you likely have barcode scanning already implemented. But really, is it fully implemented? And is the technology advanced enough to actually accommodate or require scanning of each drug container that's used? And so here, we really want to drive practice to that piece, right? So not only installing barcode scanning verification, but using it to scan each drug or vaccine package or container before it's dispensed to the patient. And obviously, this is one of those best practices that's going to require not only effort from the pharmacy, but certainly also by pharmacy computer and barcode system developers to make this functionality possible. As we think it's really important for each container used to be filled, to scan when they're being used to fill a prescription. And so some things that go along with this best practice, touched on already. Obviously, we want folks to scan each container used. But the other piece is really kind of standardizing that workflow process, where you're working on one patient's prescription at a time and employing barcode scanning to its fullest. And so, certainly we see a lot of variation in pharmacy workflow around dispensing. And so really having that standard workflow process to drive this and take full advantage of the technology is important. And obviously, touched on with the wrong patient errors, monitoring the effectiveness of barcoding and how your strategies are being followed and utilized is key. So here, obviously, there's technology and data you'll be able to take advantage of, or should be able to take advantage of, from the barcode system itself, as far as scanning compliance rates, or notations of what's been bypassed, or acknowledged alerts. But again, you want to also observe the process in person to see how things are working, then actually actively solicit feedback from your staff to learn about potential barriers with the technology or with the standard workflow process that may be leading to workarounds. All right, so that's going to move on to best practice 3. Matt, if you want to launch the poll. And here we're asking, does your pharmacy computer system require entry of an appropriate oncologic indication for daily methotrexate orders? All right, it seems like we're holding pretty steady that almost half of you don't have this, and many of you don't know, which is understandable. But thankfully, there's about 20% of you that do have this functionality available to you within your pharmacy system, which is great. Right, so we've been publishing stories about accidental daily instead of weekly dosing of methotrexate just in the community newsletter since January of 2003. All told, since early 1996, harmful or fatal errors involving low-dose oral methotrexate has been published or reported across our ISMP newsletters more than 60 times. But of course, unfortunately, we continue to receive these reports of this error. And certainly this low-dose methotrexate or weekly methotrexate, can be used for a lot of different indications, such as rheumatoid arthritis or psoriasis and other inflammatory diseases. But when this is inadvertently given daily instead of weekly, you end up having patients who experience some severe toxic side effects. And we certainly have had reports of patient deaths with this as well. And so really, like, prescribing errors happen with this, when physicians and other prescribers, right, who are typically, very familiar with dispensing and writing prescriptions for things that are daily, writing for something that's weekly is different and out of the norm. And so that introduces risk. And it's the same thing for the pharmacy end, right? So dispensing errors occur in much the same way when pharmacy technicians and pharmacists are so used to dispensing daily medications, they inadvertently select and enter a daily dosing parameters for this instead of weekly. So even beyond a number of just kind of the case studies we've published in our newsletters over the years, a few years ago, we looked at some of the FDA adverse event reporting system data around this for an 18-month period ending June 30, 2019. And that data set, we only actually found like 14 explicit cases of this, but in those 14 cases, there are 5 that actually resulted in patient deaths and 9 that patients required hospitalizations. The other piece I want to point out here is that in a lot of these cases, the damage to the patient, the harm that the patient experienced happened pretty quickly, and was really the result of daily administration methotrexate for 1 week or less. So people were having severe effects and dying, kind of within a week of starting some of these methotrexate daily regimens by accident. And as you can see here, about half of these folks involved in errors were older patients who were confused about the frequency. But then, as we pointed out on the previous slide, about 50% of these were made by healthcare practitioners who inadvertently switched daily and weekly. And I do also want to just point out that there are certainly lots of other reports in this data set that indicated severe toxicity. There wasn't enough information to specifically assign it to this type of mix-up, but certainly a lot of the information around it suggested that that was likely the case. And then the same year, there was actually an article published with some from some FDA-sponsored research looking at these dose frequency errors among Kaiser Permanente patients in Northern California. And as you can see here, they actually found that there are about a rate of 4 in 1,000 patients mistakenly take methotrexate daily instead of weekly. And so just one final case that we have from our sister organization, ISMP Canada. In this case, an elderly patient was prescribed methotrexate 50 milligrams once weekly for an autoimmune disorder. But again, like as we've been talking about, the community pharmacy dispensed a 3-month supply of methotrexate, right? So you're obviously already dispensing a lot of medication, and maybe methotrexate should only be reserved for a monthly fill rate. I don't know. But they inadvertently provide instructions on the pharmacy label to take the 50 milligrams daily. Unfortunately, this error wasn't discovered until the patient actually came back to the pharmacy to request a refill 3 weeks later. And then the pharmacist was able to identify the error and then refer the patient for medical follow-up, which ended up resulting in the patient having a very long hospital stay, including the need to receive the rescue agent leucovorin calcium. And so if you are familiar, looked at our hospital best practices, some of this is going to look familiar as was included in one of the first sets of best practices for hospitals back in 2014. And then, of course, like some of these other things with barcode scanning and wrong patient errors, some of these things are going to require interaction and support from the community pharmacy vendor and or your internal IT development department, because we really want to see those computer systems add functionality such as this weekly dosage regimen as a default to these systems to support pharmacy practice. And likewise, these technology vendors will need to participate in allowing pharmacies to do this. The second part of this best practice, which is really, sorry, skipped ahead slide, requiring verification of entry of the appropriate oncologic indication that we already talked about, and then you guys answer your question, the polling question about, so some of you are already there, but certainly we need more help with that to get everyone to the same spot. And then the third part of this is, again, this third part and really kind of the fourth part of this best practice is going to really focus more on providing education to patients. And so here we really want folks to leverage technology again to create a forcing function that ensures patient education happens with these prescriptions every time. And many of you have this. Some of this can be manually done currently by pharmacists. Some of you may have it programmatically entered into your computer system. That's where we want folks to get to, right? Be able to leverage technology to create a forcing function around making sure patients are educated. And then, of course, comes the actual education piece of it, and using a teach-back method to provide this education to patients for all oral methotrexate prescriptions, whether it's new refills or new fills or refills, and really thinking about working with the patient to specify which day of the week they want to take it, providing clear oral and written information, thinking about, and we're hoping folks will take advantage of it, providing patients with, the free ISMP high alert medication consumer leaflet on oral methotrexate that certainly is designed to give them pointers for how to avoid accidental errors with this drug. So really kind of two pieces. That technology piece is, of course, making sure we have the right information to dispense it safely, and then making sure we can engage patients in patient education. If you want to launch the next poll question map. And this one is asking, do you dispense metric-only dosing devices to your patients? There you can, about half of you are doing this. That's great. It's awesome. So as you can see, so about 40% of you are doing this. Some of you aren't, so hopefully we can move the needle and encourage you to do that. And some, certainly also may have them available for purchase, which is fine, but we're hoping to get folks to get to the point where we're actually providing these devices for our patients. All right. So as you can imagine, this best practice is around, it's going to be around standardized metric units for oral liquids and for patients. And certainly, again, much like methotrexate, we've had mix-ups between the different various units of measure for oral liquids going back as far as at least 2000, when we first reported on it. These can be confusion between teaspoons and tablespoons, or milliliters and teaspoons, drams and milliliters, you name it, we've seen it all over the board. And most typically, right, when these errors happen, they result in multifold dosing errors. And so, we continue to see these. We've had dozens and dozens and dozens and dozens of these cases reported to us over the years. Most often, they're impacting children, and they're leading to injuries that are requiring treatment, or in some cases, hospitalization. And so, just to provide one example here, we had a case where a 2-year-old child with an ear infection ended up receiving a 5-fold overdose of their antibiotic for 3 days. Again, the pharmacist accidentally typed a label that gave instructions to give the child 3 teaspoonfuls of antibiotic daily for 10 days instead of 3.5 mLs daily. By the 4th day of treatment, the parents were running out of medication, and so they came back to called the pharmacy to follow up, and that's when they actually found the dosing error. But in the end, the child unfortunately experienced a lot of adverse effects, as you see here on the slide. Required follow-up with the physician, and also increased monitoring, as the child had a history of Clostridium difficile infection in the past. And so, I mentioned we've had dozens of these reports. We've written about it, but we've also had some kind of larger calls to action around this, going back to 2009. Even 2011, we added these drugs to our high alert list for community ambulatory care, ambulatory healthcare, trying to push, especially that patient counseling piece that really need to take care and looking at these prescriptions and working with patients to make sure they know how to properly measure them. And then, again, this, more recently in 2011, again, with our board calling for healthcare to only use metric measurements. I also want to mention this, pardon me, it's not included on this slide, but certainly there are others too that have engaged in trying to push this needle forward as far as standardized to metric only, and that's the CDC Protect and NCPDP, who collaborated to write a white paper a few years ago, really pushing pharmacy practice to standardize to metric only. But again, despite all these things, we continue to see these error reports happen, impacting our pediatric patients. And so we really want pharmacies to set up a process to standardize to the use of milliliter unit only. Ideally, it starts at the prescribing end, but certainly when dispensing and measuring oral liquids. And to go along with that, to support that, right, we want pharmacies to be purchasing and dispensing metric only dosing devices, which about half of you already are, and making sure that they're an appropriate size for the prescribed dose. So, if a dose is 2 mLs, you don't really want to dispense a 10 ml syringe. You want to do a 5 ml syringe or a 3 ml. So making sure they're metric only, but also of appropriate size. And then again, engaging patients and parents and caregivers with that needed education using the teach back method to make sure that they can actually measure and administer the dose properly. All right, so now we're getting to the last of the 5 new best practices. And if you want to launch the last question poll, great, thanks, Matt. And so here the question is, does your pharmacy share with staff stories of errors that happen outside of your specific pharmacy? So, if you're in a chain or a mass merchandiser, like, do you share stories that happen in a different store, with other stores in the chain, or different, or things from even completely outside your organization, from a different chain or independent? Great. So yeah, again, so majority of you are doing this. This is good. As you can see, so about 69% say yes. That's great. But obviously there's still room for improvement. So appreciate everyone's responses. And so kind of one of our hallmarks, right, at ISMP, and one of the things we've been preaching over and over again, and really kind of is at the core of all that we do, right, is really one of the most important ways to prevent medication errors is to learn from others that have experienced those medication errors, right? And to then use that information to identify potential risks in your own system and practices, and then make changes, right? So, pardon me. Our experience has shown, that a medication error reported in one organization, right, is likely to happen in another. And so it's really important to seek out those external sources of information and errors to prompt that internal investigation and risk mitigation and minimization within your organization, right? Because I think most of us know, right? There's a certain amount of inertia internally that we tend to, normalize errors that happen elsewhere, and so you might think that this is kind of a contradiction, that we want people to learn from external sources, but there's also this tendency to normalize errors that happen elsewhere, that thinking that they'll never happen in our pharmacy, which of course we know it's not true. So it's really incumbent upon leaders, the pharmacy managers and the leaders, to convey that these external errors really offer valuable and necessary learning opportunities, and really need to be sought out and reviewed regularly. And that these are clear and present dangers to your pharmacy practice, even though they happen somewhere outside, and that steps need to be taken to prevent similar occurrences within your organization. So really, in the end, why wait to learn firsthand about some of the errors we talked about today, like the methotrexate errors, for example, when you can actually be learning about these from other folks. Sorry, I had a pause on that slide. And so then the final best practice wording is here. And again, this is something that's similar to what we have included for our hospital set as well. Again, seeking out and using information about medication safety risks and errors that have happened elsewhere, to learn about them, but then to take action to prevent them in your own pharmacy. And to go along with that, right, we kind of think about these as kind of creating a process to do this, as well as then sharing things within your pharmacy. So here, certainly wanting to create source processes to identify reputable sources of information externally. So that could be our material, our community ambulatory care action agenda that's published 3 times a year. It's free on our website. Things from regulators, things from FDA, CMS, accrediting bodies. All these different organizations can provide valuable information to use to drive this change, and then to establish this process for reviewing these errors internally and determining and identifying the risk points, and then identifying strategies to implement. And then finally, the other piece is the kind of that sharing piece, right? So it's fine and dandy to do all this work internally within committees to identify these things, but then you need to share these stories with all staff and all pharmacy locations if applicable, and if possible. And then, so not only sharing the stories, but then also combining those and marrying those up with any changes that are actually going to be made to minimize the occurrence, that really drive home the importance of the changes and strategies that you're implementing. And of course, like we mentioned before, going to need to set up ways to monitor these activities to make sure that they're actually working. If they aren't, then you're going to have to come back and revisit and make changes again. But so identifying sources, developing processes to use the information, sharing the stories, and then monitoring that improvement and success with those strategies that you implement. And that is it. And Matt, I think this is your slide.
Yeah, thanks, Mike. And everybody's seeing this slide. This is also on handouts, by the way, the link to get the CE, the attendance code at the bottom, and the date and so on. So on that note, Mike, we got some questions in the Q&A box. I'll go over with you for time runs up. And Mike, there's 2 general themes. Excuse me. Now we're going to kind of merge some questions together. One is with what gets reported to ISMP. Because people are asking, for example, Have we seen differences between community pharmacies and home delivery pharmacies? Have we seen an uptick in wrong patient errors during the pandemic because of curbside delivery? And also another related one would be whether we see more reports because of maybe prescribing frequency, as an example. So any just comments about the reporting that we see and the stuff that we get, Mike, to answer those questions?
Sure. Yeah. I mean, we certainly see errors both in community kind of storefront practices, but also in settings like specialty pharmacy. I wouldn't say we get a ton from mail order, but certainly practices that ship or deliver medications to the patient somewhere. So we're seeing some of these same errors across those, and certainly know that specialty pharmacies struggle with wrong patient errors during the delivery process, and there's a number of things that happen in there. I would say we did see, I don't know if we saw an uptick in wrong patient errors or some of these errors with code, but certainly like the person pointed out, we did see them in different points, at different interaction points with the patient. So right, curbside delivery, and some of those things were certainly made more difficult. So I don't know that we had more errors, but certainly reports where things were made more difficult because of COVID, because of some of the barriers that were put in for protection, and things like that. I'm sorry, I forgot the second part, Matt, that you're asking me.
That's okay. That was just basically what we're, the type of reports we're getting, because people were asking very specific stuff about the type of reports we see, when the reality is people aren't reporting that quantity to us, everyone. Like, we're basing our life and our stories based on really anecdotal reports, not based on quantifiable millions of reports. My other question, and this is going to revolve around our role with FDA and packaging and labeling overall. For example, Tabitha says most of the dual component vaccines don't have barcodes to scan both components. Have we worked with manufacturers? People make comments about the look-alike packaging you saw earlier, Mike, as an example. And why are producers allowed to make similar containers? So I don't know if you would just comment on our role with the FDA and all those issues.
Sure. Yeah, and we certainly reach out to manufacturers, and we have an actual MOU, memorandum of understanding with the FDA. So we actually have, well, we share all of our reports with the FDA to begin with, but then we actually have monthly meetings with them to go over different things, whether it's barcode quality, missing or multiple barcodes on containers, look like container issues, look like name issues, and really try to advocate for changes around that. So certainly you've seen some changes over the years. It's not 100% across the board. Certainly we're still seeing look-alike packages, but just thinking of some of those like patches that once upon a time had multiple barcodes on it, we're able to advocate and get some of those removed, so you can actually scan the correct barcode and get it to work. But it's a continued work in progress, right? So like I said, we continue to work with FDA, have monthly meetings with them to go over specific issues and try to advocate as much as possible. Then also reach out to the manufacturer. So if it's a manufacturer related issue, we certainly do that. And we try to do the same thing with technology. It's a little bit harder on the community pharmacy, especially if you think about errors that start on the prescribing end, because we don't always get the information about the prescribing system. But certainly we reach out to technology vendors when we can. This includes the drug information vendors. If we think some of that content may contribute or could be tweaked to improve safety, we certainly try to do that as well.
Great. Thanks, Mike. So on that note, everyone, it's at the top of the hour. So I want to thank you all for attending. First off, I also need to extend our gratitude to Novartis Name Creation and Regulatory Strategy for sponsoring this free webinar for everybody. And just to let you know, it's not on our site yet, but it'll be posted within the next couple of days. Our next webinars will be a two-part series on drug diversion on February 15th and March 15th. Part one of the two-part series will highlight the role of a drug diversion specialist or program manager with a system-wide responsibilities for all drug diversion related processes and responsibilities. March 15th, on the topic of drug diversion, will include discussions from a corporate risk manager and their role in looking at and investigating drug diversion scenarios, as well as a infection control preventionist, to talk about the role of infections in drug diversion as well. So again, thank you again to all of you for joining us for today's program. We hope to see you next time, and this now concludes our webinar.